done the introduction, we have done filtration. We have talked about the dynamics of filtration, how filtration happens, what are the forces, what are the factors acting on those areas. We talked about the factors also which can increase or decrease the filtration. Now it's time to see the GFR. GFR is a very, very important parameter of the kidney. We have to see how GFR is maintained in the body because it is very, very important to maintain the functioning of the kidney. GFR is actually representing the function of the kidney. It is one of the renal functions. Okay? So it has to be maintained normal. Kidneys are very smart in maintaining the GFR. The maintenance of the GFR is called the regulation. Now we are into the area of regulation, how GFR is maintained. Many factors can increase or decrease the GFR because we are humans and we are affected by so many factors. But our GFR will not remain high or low. Quickly it comes back to normal. Coming back to normal is your regulation. Okay? So now we are starting the process of regulation. Let's have a look. Half of this discussion will be known to you, I'm sure, because you have done circulation and you are pretty much done with the special hormones of the kidney and renin-angiotensin system also. So you will not find it difficult really, it's very easy. So factors regulating the GFR. Okay, Shabab, please have a look. In the previous lecture, we talked about one of the three major forces, glomerular capillary pressure, and we declared and discussed that the glomerular capillary pressure is the most important pressure which is actually determining the GFR. Even though plasma proteins are important and the woman's capsular pressure is also important, but look at the force, the real force which is causing the GFR is glomerular capillary pressure. Do you agree? Okay? Alright. So it means if you are talking about the regulation of the GFR and if you have to select one of the three major determinants, you will focus the glomerular capillary pressure. How can you regulate the glomerular capillary pressure? The most important thing. Proteins don't change very easily. Woman's capsular pressure does not change very easily. So your main focus is on the hydrostatic pressure, yani the capillary pressure. Now have a look. You've got many things. Sympathetic nervous system is acting on the kidneys. We'll see what is the role of the sympathetic nervous system. There are some local hormones and the local vasodilators and vasoconstrictors which are released by the kidney. They will also try to affect the filtration, definitely, because they are changing the resistance. Okay. So let's begin. These are the issues, and then we talk about a very special attribute of the kidney. I told you, kidneys have a very special function of auto-regulation. I use the word auto-regulation, yani self-regulation. I think we were talking about the renal blood flow. Do you remember? Okay, I said that renal blood flow can be maintained by the kidneys themselves, and this is called self-regulation or auto-regulation. Well, your GFR mainly depends on the renal blood flow. Now we have decided. So GFR and the renal blood flow together, they are auto-regulated by the kidneys. The kidneys are regulating these two things, GFR and the renal blood flow, by some own mechanisms or intrinsic mechanisms. The other mechanisms are not really affected to a great extent. We'll see that. Okay? But let's start with the sympathetic nervous system. Does it really have a big role in the regulation of GFR all the time, throughout the day, throughout our life? Well, sympathetic tone is always present in the blood vessels. And it is trying to maintain the size of the blood vessel. We know that. It's molecule always. Sometimes it can increase, sometimes it can decrease, but at other times it is maintained. Okay? Well, with a normal tone of sympathetic system, or with mild or moderate sympathetic stimulation, well, the kidneys are not really affected. The afferent arterioles and the interlobular arteries and the efferent, they are not really much affected by that. The change comes when there is a strong, shadid sympathetic stimulation, and I gave you an example. What example did I give you for strong sympathetic stimulation? Shock-like condition. All of a sudden, dehydration or shock, then the kidneys will receive a very strong sympathetic stimulation, and then that will affect the GFR at that time. But otherwise, under routine conditions, sympathetics are there, but they are not doing really much of regulation. So, are sympathetics really very important in regulation all the time? No, not really. At a certain point of time, they help in regulation, but not throughout. Okay? They contribute to some extent, but it's not the major role, right? So, for sympathetics, keep it aside, not a major role. Module, but not a major role. Okay? The second thing is about the local hormones. I talked to you that there are some small hormones which are released by the kidney tissue, and they are acting locally, and they are working on the afferent arteriole, on the efferent arteriole, and they are working on the interlobular arteries. So they are having a local action. They are not coming from outside, from adrenal gland, or coming from pituitary, or coming from GIT or pancreas. No. They are produced and released locally in the kidney. Dakhli hormones, actually, you call them. Okay. Some of the hormones, okay, are released by the sympathetic nerve ending. You know, we have talked about sympathetics. Catecholamines. When I say the word catecholamines, how many of you know about catecholamines?
Epinephrine, norepinephrine.
Okay. Alright. But still, the whole class is not with us. You are still working on your mobiles. If you stop working on the mobiles, this mobile issue is a big problem, really. I cannot have it, not with you, even with my children, really. They don't listen to me. Okay? The moment I don't see them, they just take it out and start working on that. I don't know what magic does it have. It's an addiction, really. And you can't just stop. Not only your age, even of my age or anyone, whenever they're sitting, they just take out and they're having us putting the fingers and working on the mobile. Okay? So, this habit should be controlled, really. Okay? It's very important. It takes a lot of time. Catecholamines, yes, coming back. Catecholamines. What do you think about them? Hormones. Which hormones? Name is written here. Is there any other? Dopamine. Add one more. Okay? Catecholamines is a group. Epinephrine, norepinephrine, and dopamine together. Okay, one group of hormones, and these are called catecholamines because they have a very special structure, catechol nucleus. Okay. Now, these are vasoconstrictors. You all know that.
Yes.
All right. Very simple. Look at the symbols which are written here. Do you see the afferent arteriolar resistance here?
Yes.
Do you see the efferent arteriolar resistance also here?
Yes.
Alright. So catecholamines are doing what? Now you see the equation. They are increasing or decreasing the resistance. What are they doing?
Increases.
Are they working more on afferent or efferent? Okay. So it gives you a comparison that catecholamines have a greater affinity for afferent arterioles. So they work more on the afferent arterioles. And the control of afferent arterioles is probably more important actually. To control the blood flow. Which arteriole is more important? Afferent is more important. Okay. So the result, look at the result. What are you doing to the GFR?
Decrease.
And what are you doing to the renal blood flow in general, which is coming?
Decrease.
Which one is affected more? The GFR or the blood flow?
Blood flow.
Okay. So the number of the arrows is telling you the situation also. Now look at another hormone that we'll talk about later. Okay? It's angiotensin 2. Just have a look. Where is it working? Efferent. It's not afferent arterioles. Okay? And why? Why have we missed the afferent arteriole? They're very, very important. Why is angiotensin 2 missing the afferent arterioles and just going to the efferent arterioles?
Because it's related to retention.
Reabsorb.
Reduced by
angiotensin 2 is present in the blood. Alright? It is coming in the afferent arterioles, it is there in the glomerular capillaries, it is there in the efferent, it is working it is working in the efferent, it is first passing through the afferent, and it is leaving the afferent, just ignoring it.
Didn't activate. It didn't activate in the glaminar?
The question is why, when it is passing through the afferent in the blood, it is present in the blood. Receptors, thank you very much, lovely, okay? It's simple. If the receptors are present, the hormone will go. If the receptors are not there, what can hormone do? It will pass simply, isn't it? So the receptors are present in the afferent arterioles, do you think?
Yes.
No. Are the receptors present in the glomerular capillaries, do you think?
No.
The receptors are present only in the efferent. If there are a few receptors in the afferent, they are almost negligible in number. No effect. So your main effect is not the afferent, it's not the glomerulus, it is actually the efferent arteriole where you are working. Okay? So keep it in mind, that's why. That's the reason. And what is the result if there is angiotensin 2? And the renal efferent increases. And if it is a large amount of angiotensin 2, then what will happen? It will be a biphasic type of effect. Initially there will be an increase, okay? But if the hormone concentration keeps on increasing due to some reason, then you may have an increase and then coming back to normal and maybe a little decrease. Yani biphasic effect. Do you remember that?
Yes.
No? Alright. So here the biphasic effect actually is seen as an increase and then coming down to the baseline, to the normal. Usually with angiotensin 2, your GFR does not decrease, it increases and then it comes back to the baseline to keep it normal. So an increase and normal effect is there, but not true fall in the GFR. Okay, this is the property of the angiotensin 2. So keep it a little different. Previously we discussed that if the efferent is totally constricted, it will have a true biphasic effect. Awal increase and then it is decrease. But if there is angiotensin 2 usually causes a moderately severe constriction, not a total closure. If it's not a total closure, a moderately severe constriction, then what do you expect? An increase and then a slight fall up to the maintenance level, and it will maintain. Alright? So did you get the difference? If it is totally closed, what will happen? A true biphasic effect. If it's angiotensin 2, well, it looks like a biphasic effect, but actually it's an increase and then maintaining that at the normal level. It will come down, but then it will be at normal level, not going down below the normal. You find the difference? Okay. Local prostaglandins. Prostaglandins are some special hormones. I am sure you have heard about prostaglandins. They are present in every tissue of the body. Some are vasoconstrictors, some are vasodilators. It's a mixture really. It depends. Prostaglandins are in the kidney. Most of their action is dominantly dilator action, and the quantity of the vasodilated prostaglandins is more which is released. Okay? So if it is vasodilation, what will happen to the resistance of the afferent arteriole? And the GFR will increase, and definitely by dilation the blood flow. Now you are comparing GFR and renal blood flow. Which is usually increased or affected more, GFR or the blood flow?
Blood flow.
The GFR also changes, but the GFR changes are not equal to the blood flow changes. The blood flow changes more actually by constriction or dilation. And the GFR is then affected because GFR depends on other factors also. That much. Okay? There is another vasodilator which is released. Okay, it's the nitric oxide or EDR, released by the endothelium. It's a vasodilator. So what do you expect if it's a vasodilator and acting on the afferent arterioles? What will happen? Opposite also. Easy. Okay, same type of change really. Okay, it's simple. So in principle, you have learned few things, that vasoconstrictors and vasodilators, are they affecting afferent arteriole more or efferent arteriole? Generally speaking, afferent. Okay? There is one special vasoconstrictor, very one special vasoconstrictor which is only affecting the efferent arteriole. Yeah. Okay, and you know the reason why. And when you are comparing the changes in the GFR and the blood flow, you will see that the blood flow is affected more as compared to the GFR. Alright? So this is your essence which you have learned in these slides. Now we are coming very carefully into the area, the true regulation. Actually, the regulation of the blood flow and the GFR is done by the kidneys. The small factors are helping, but the major role is played by the self-regulation, auto-regulation. Please magnify this word in your mind, auto-regulation. When I talk about kidney, a quick word in the blood flow and the GFR regulation is auto-regulation, self-regulation, please. Okay? Keep it in your mind. Kidneys and regulation of GFR and blood flow, last. One word, auto-regulation. Look at the auto-regulation mechanism. There are several mechanisms of the auto-regulation. Very interesting. One mechanism is called myogenic mechanism. Okay, number one. The second mechanism here is called the macular densa feedback. Okay? And the third mechanism is angiotensin 2. Alright? Okay. Myogenic mechanism, the first one, please. Myogenic mechanism is about the structure of the blood vessels, not related to the hormones. Okay? Changes in the blood vessel wall automatically with the changes in the blood pressure or the blood flow. Well, the myogenic mechanism says that whenever there is an increase or decrease in certain increase or decrease in the blood pressure coming to the kidney or the blood flow coming to the kidney, obviously it will affect the blood vessel. Okay? If more blood pressure is there in the blood vessel or more blood is coming into a blood vessel, what will happen to the wall? Stretching, right? Okay. Now, stretching is happening, increasing the size, quota of the blood vessel, oval. First thing, okay, because you're stretching. Okay. Now let's see what happens after that. Okay. You are stretching the wall. It means you are stretching the structures of the wall. In the wall of arterioles, the most important thing is muscles. Smooth muscles, right? Yes. Smooth muscles are there. They are stretched. Now look at the property of the smooth muscles. This is myogenic. Now you will see what happens with these smooth muscles. Okay. Myogenic. Okay, mechanism. Look at this mechanism. Now try to work on this algorithm or the flow chart which is written, that how the myogenic mechanism is helping to normalize the blood flow. For example, a large amount of blood flow due to some reason is coming into the kidney. Okay. Now the blood vessels are not expecting that, and there is stretching of the blood vessel. Now what will be the response of the blood vessels? Let's have a look. Okay. So first thing you see here, just have a look at that picture. Okay. Keep looking at the picture. All of you, please. Please at the back. Just because you are distant, it does not mean I cannot see you. You are still working on the mobiles. No use. Just like my children. Okay. All right. So, arterial pressure increases, and that is causing the stretch of the blood vessel. Okay, so this time the pressure change is happening. Okay, let's take the pressure instead of the blood flow. Pressure. Okay, a large change in the blood pressure stretches the blood vessel wall. If the blood vessel is stretched, definitely the muscles are also stretched. Do you expect? When the muscles are stretched, there are some channels open due to stretch, and the calcium will enter into the smooth muscle. You know, smooth muscles depend on the extracellular calcium for their working or contraction. They don't have the store, they don't have any mustala inside. They just need calcium from outside. Stretching means more calcium into the smooth muscles. If you provide more calcium to the smooth muscles, what will they do? Oh yes, they are waiting. They will contract. When they contract, what will happen to the blood vessel? Yeah, decrease size. After stretching, it will get back, it will try to get back to its normal size to maintain it, really, okay? It will not remain stretched. It will come back and try to oppose the change, okay? So, when the blood pressure was increased, the stretch happened, and due to stretch there is vasoconstriction, and that vasoconstriction will increase the resistance, and that resistance will try to kill the blood pressure. When the blood pressure is killed, definitely, again the blood flow which is going into the glomerulus will come back to normal or a little less value, isn't it? This is called automatic regulation. You are not doing anything from outside. You are just stretching the muscle, you are causing reflex vasoconstriction, and you are increasing the resistance, and by increasing the resistance, you are again controlling the blood flow. That's it, okay? So it's totally myogenic mechanism happening inside the smooth muscle. You are not taking help of any hormone, you are not taking help of the sympathetic system, you are not taking help of any other thing, no chemical. It's a pure muscle system, intrinsic system. That's why you call it myogenic. Myo, muscle, genic, coming from. So it's coming from. That's it. Any problem in this one? Alright. Well, forget about everything. The whole story, our focus for the regulation of the GFR, okay, it stays around a very special mechanism, and that mechanism is called tubulo-glomerular feedback mechanism. First try to understand the meaning, okay? Just don't go listening to the term that, okay, it's a mechanism, maybe I'll memorize it later. Look at the name of the mechanism first of all, okay? Why have we named it like this? It has three parts.
7 cubes.
Well, definitely in this system, tubules are involved, right?
Yes.
What else is involved in the system? And this system is showing you feedback. It means it's a feedback system. If it's a feedback system and it is a regulatory system to keep things back to normal, will it be a negative feedback system or a positive feedback system? Well, first of all, recall, I think some of you are still forgetting that what is the difference between a negative feedback and a positive feedback system. Okay? You must keep it in mind very clearly. A negative feedback system will bring your changes back to your baseline value or the normal value. A positive feedback system will keep on increasing an effect or decreasing an effect. It is going in one direction only. Okay? So a positive feedback system is going forward and forward and forward, or backward and backward and backward, in one direction only. Okay? The negative feedback system is very special. If anything is increasing in your system, it will try to decrease it, getting back to normal. If anything is decreasing in your system, again it will work and try to bring it up to the normal value. Now, what do you want? Negative or positive?
Negative.
No. Correct the concept again. Okay? Your GFR is increased. Okay? You want to bring it back to normal. Alright? If you want to bring it back to normal, are you working on the negative system or a positive system? Negative. Agreed? Everyone. Okay? Because if you disagree, we can discuss this. You must make it very clear. So GFR increases, what will happen? You will try to bring it back. GFR decreases and you are bringing it back to normal. Is it negative or positive? Again, it's not very clear. Okay, that's clear. This is normal. Okay? If you are increasing from the normal and bringing it back to normal, it's negative feedback. Okay? Agree? So any increase and coming back to normal is a negative feedback system. Now, you are decreasing and again bringing it back to normal. Back to normal. It is also a negative feedback system. Alright? So both are negative feedback. Don't think about increase or decrease. Are you coming back to normal or not? Okay? If you are coming back to normal, it is. And if you are going by from the starting value, like this or like this is a positive feedback system. Okay? Got it? Okay. Please, Shiva. Tubulo-glomerular feedback is a very strong and very special autoregulatory mechanism working in the kidney. Very fascinating. It has two parts. It has two parts. You can divide the feedback into two parts. The first one is afferent arteriolar vasodilator feedback mechanism. Okay? So the first part is focusing which arteriole? Afferent. Okay? And what is happening to that arteriole? Dilation by the feedback. Okay? So answer is modued in the whole sentence. Okay? Afferent arteriolar vasodilator feedback. So in this feedback mechanism, your result will be dilation of the afferent arterioles. Okay. Now look at the other mechanism: efferent arteriolar vasoconstrictor feedback mechanism. Now you are working on efferent, and what are you doing to the efferent? Constriction. In both ways. Now look at your knowledge which you have and just try to relate. If you are constricting the afferent or constricting the efferent or dilating the afferent arteriole, what are you trying to do actually? Yeah, you are trying to improve the GFR, isn't it? In both ways actually. Okay? So actually this whole story is around the improvement of the GFR. It means if the GFR falls to a low value, then there is a problem. If the GFR increases slightly, okay, it is not a big problem. It will cause more filtration, more urine formation. But if the GFR is decreased, then there will be a problem in the renal function. It means one of the renal function is decreased. So you are actually taking care, by this mechanism, what are you doing? You are basically taking care of a decreased GFR, and you are trying to bring the decreased GFR to the normal value. Alright? Okay? So these two feedbacks together, when you have afferent mechanism and efferent mechanism, if you combine these two mechanisms, the name will become tubulo-glomerular feedback. If you want to break tubulo-glomerular feedback into two parts, you will say afferent and vasodilator and efferent vasoconstrictor mechanism. Are we clear?
Yes.
Can we keep the mobiles inside the pockets? Thank you very much. Alright. Now please. Okay. How many of you are familiar with this diagram? Okay. What else? Try to identify histology. Your histological capabilities. You are identifying the structure. It's not physiology here. It's on structure shown here. Okay. Okay. All right. Renal corpuscle. Good. What else do you see? Try to find it out. All of you, look at the board, please. Okay. Juxtaglomerular is impressive. This term is coming. You know about this term? Juxtaglomerular apparatus? Yes. Okay. Who took your lecture? Dr. Ashraf, Dr. Fateh? Both. For this one? No. Divided the kidney into histology into different parts. Who took? Dr. Ashraf took this part, and the later part was taken by Dr. Fateh. Dr. Ashraf Mahmood, not Ashraf Barghati, right? Okay. Alright. Look at this structure, please. Can you identify the afferent arteriole?
Yes.
Alright, in this diagram. I'm talking about this one. This one, okay? This is a better diagram. This is another view, okay? Afferent efferent is modules here, but look at this diagram. Can you identify the afferent arteriole in this diagram?
Yes.
Okay. Can you identify the efferent arteriole?
Yes.
Alright. Do you think afferent and efferent arterioles are making a zavia or an angle?
Yes.
Okay, like this. This is the angle. Okay? And in the angle, there is something which is present. What is that? No. In the angle, what is present there? Distal tubule. You see a cut section of the distal tubule. So it means distal tubule is passing. This is the distal tubule. Sure. This is afferent and efferent arteriole. And distal tubule is coming from here and it is passing from here. In the zavia between the afferent and efferent arteriole, the distal tubule is passing like this. Okay? And if you cut it like this, it will be the cut section. See? Now you see the cut section of the distal tubule. Do you see that? Okay. Now focus the distal tubule. The part of the distal tubule which is present and touching in the angle, which is touching the angle. Okay? Do you see any change in that part of the distal tubule?
Yes.
Well, are the cells same or different? Different. What difference do you see in the cells? More columnar. Okay. What else? Smaller. Tightly clustered, elongated cells. Okay. Narrow and elongated cells. Columnar. And
It's close from both.
more in number in small area and
Close from different and different.
Okay, oh, very good. What else? One more change. Dark. Who said dark? Who said dark? You. Okay. Can you see the difference in color also?
Yes.
They are dark in color. It means they are filled with substance or granules, something like that. They are dark appearing.